too. Okay, so I'm going to give an overview today. Introduce myself again. Paula Hertel, hepatologist, pedi hepatologist at Texas Children's in Houston. I am so grateful to be here and so excited about the invitation to be a part of this amazing conference once again. I find it so inspiring to interact with all of you as families of kids affected by PFIC and by all of the amazing science that we're going to hear about. So I am going to address questions, or I'm going to give an overview about medical and non-transplant surgical treatments for PFIC. And specifically, I'm trying to address a number of questions that were posed by parents who got in a room together and decided this is what we'd like to hear about. So I'm going to do my best to address those questions. Before I move forward further as well, I want to acknowledge that there are a number of very big brains in this room that have actually conducted the research that made these treatments possible. And so if I stand corrected or if there's anything that you want to elaborate on any of the things that I'm speaking about, please feel free to chime in. So I don't have any disclosures. And I say that because I'm going to be talking about a number of medications, and I have no interest in trying to sell them to you for my own personal gain. So brief outline. I'm going to start by talking about medications used in management of PFIC, an overview, some of the older medications that have been used for many years, and address the IBAT inhibitors specifically. And then about non-transplant surgery or biliary diversions, procedure types, benefits and indications of each, and who are candidates, who are the best candidates for each of these surgeries. So I'm not going to talk about emerging therapies. That's coming up next session. So if you have any questions about those, keep your questions, write them down, and you can bring them up later. So medications used in the treatment of PFIC. So this is an overview taken from a very nice review about medical therapies for PFIC. What are the drug targets for cholestatic pruritus? So we have an array of different medications, and they all have different parts of the pruritus, I'll say the mechanism that causes pruritus, and they target different parts. So first of all, we have medications that have action in the central nervous system. These include sertraline, naltrexone, and they act on the nerves and the brain. Another area where you can target pruritus is by medications that act in the gut. That includes cholestyramine, rifampin, and IBAT inhibitors. And finally, there are medications that actually have their action in the liver and or in the bile or bile ducts, and those include rifampin and ursodeoxycholic. So first, I'll just talk about the bile acid binding resins. Cholestyramine is the one that we use most commonly in the US. I'm also going to toss in that I'm not specifically addressing different names or different uses of medications that are not approved for use in the US. But if any of you have questions about those, please bring them up, and there will probably be people in the room that can answer. So cholestyramine and other bile acid binding resins are actually frequently considered a first-line therapy for pruritus. They bind to bile acids in the intestine, causing the bound bile acids to be excreted in the stool along with the resin. And historically, they were used to treat high cholesterol. We have other drugs now, though, statins, as you're probably aware. The cholestyramine specifically is only available in a powder form, and I think that's the main barrier to use of this medication. It's pretty unpalatable. I've had very few patients that are willing to take this multiple times a day. It's reportedly disgusting. I probably should try it myself before I prescribe it again. Another complicating factor about these medications is that they may bind other medications, so you have to be very cognizant when you're taking them that they need to be taken 4 hours before and 1 hour after any other medication. So that's a pretty big, it makes these medications very difficult to take. Side effects are pretty mild. They're GI effects, including nausea, vomiting, bloating, constipation. Antihistamines, including hydroxyzine, also known as Atarax, and diphenhydramine or Benadryl. They can help control milder pruritus. They're nice to be used as kind of like a PRN as needed medication, maybe on top of other medications that you're using. They're not very effective for moderate to severe pruritus. Main side effect, especially with Benadryl or diphenhydramine, is drowsiness, but that actually can be a potential benefit if you're taking it at bedtime and your itch is keeping you awake at night. Ursodeoxycholic acid, otherwise known as ursodiol, is a synthetic or an artificial bile acid, consists primarily of deoxycholic acid. Its name is derived from the fact that it was originally crystallized from bear, which is urso, bear bile in 1927, and it's not from bears anymore. It's synthesized in a lab or in a factory. It improves bile flow by stimulating cholangiocyte or bile duct epithelial cell secretion. It also makes bile more hydrophilic or water soluble, which is less toxic to cell membranes and less absorbable in the intestine. So it kind of has a multifaceted benefit. It's an effective therapy for a variety of cholestatic liver diseases, including PFIC. It is like the primary treatment for PBC, which we don't see in kids. It can prevent stone formation, which is a potential complication in BSEP and MDR3 disease. I'm going to try and stick with the protein, referring to the proteins rather than the PFIC disease names during my talk. It may alleviate pruritus. It may not. It varies. It may slow or reverse progression of disease, primarily in BSEP disease or MDR3 disease. 1+, it's taken twice a day, and it's generally very well tolerated. So I think most of our patients are on this. Rifampin, also called rifampicin, this is an antibiotic that can alleviate pruritus by more than one mechanism as well. It increases the metabolism of circulating itch-generating compounds, and it promotes their excretion in the urine. And in the gut, it alters the composition of bacteria or the microbiome in the intestine because it's an antibiotic, and that can affect the metabolism of itch-producing substances in the gut. One complicating factor about this medication is that it increases cytochrome P450 activity in the liver. That is a that affects drug metabolism. So if you start it, it could potentially decrease blood levels or effectiveness of some medications. So you have to be very attentive to what other medications the patient is on. And likewise, if you're on rifampin and you're on other medications, we have to be mindful that if you stop it, that the levels of other medications that you're taking, if they are metabolized by P450, could potentially rise or even potentially develop, rise to toxic levels. Side effects, I always give my parents a head up before I prescribe this that your urine will become orange-red in color. That can be a little alarming. And in some cases, it may cause elevation of liver enzymes, so it's something to keep an eye on. Naltrexone, you can see I'm pulling up a little snippet from that first slide that I showed. Naltrexone is circled here. It acts on the peripheral nerves to block opiate or pain-relieving receptors. And we know that it works basically, we think that cholestatic itch is at least in part mediated by the same mechanism that, say, morphine. I don't know, for any of you that have been in the hospital and received, say, an IV dose of morphine, and it might have made you itch. Well, part of the mechanism of the morphine making you itch is through opiate receptor stimulation, which is part of the mechanism for cholestatic itch as well. So naltrexone blocks those opiate receptors, and in that way can reduce itch. It may cause elevation of liver enzymes, so we have to watch that. One downside is it's not available in a liquid or a compound form, so we have to give it by tablet and crush it. And in a small kid, we have to give a small part of a tablet. One consideration for this medication as well is, for example, if we have a patient who's on the transplant list and anticipating a potential transplant at any time, that we're blocking these opioid receptors, so it could actually result in increased pain postoperatively. So if we can, we try to avoid prescribing it when we think someone is going to be undergoing surgery imminently. Sertraline is, you can see here, it's from the picture in the corner, it acts in the brain, actually. It is called a selective serotonin reuptake inhibitor, or SSRI type medication. These medications are commonly used for treatment of anxiety and depression, but it also relieves pruritus. It's believed to occur via direct action in the brain. As I said, I think that its exact mechanism for its effects on pruritus are unclear. It's safe and it's generally well tolerated, and it has only a once daily administration. I've seen it work very well in a couple of patients, although it's not very commonly used for this purpose. So IBAT, or intestinal bile acid transport inhibitors. This is a new class of drug that I think we're all excited about. We've got 2 of them that are currently approved for use in PFIC as of last month. So in this diagram, I show how do they work. We've got the liver here, the bile is excreted, goes down into the intestine, and your bile acids then travel down through the small bowel. And in the ileum, this is where 95% of these excreted bile acids are reabsorbed into the blood circulation and carried back to the liver, called enterohepatic circulation. And IBAT inhibitors block the transporter, which is a protein in the wall of the intestine that allows the bile acids to be reabsorbed into the serum. So we're blocking it right here. It blocks bile acid reabsorption. And this is basically kind of the medical version of a biliary diversion surgery, actually. So we block absorption into the blood, and we also, as a consequence, we have increased excretion of the bile acids in the stool. So we're getting rid of some of the bile acids, and it results in a lower level of circulating bile acid levels in the blood as well. So first one that was approved for PFIC is odevixibat, trade name Bylvay. I just kind of tried to put it on the bottom of the slide there. This was first approved in the US. Again, I'm just referring to the US for simplicity, for PFIC in 2021. And currently it's approved in the US for children with PFIC ages 3 months and up. It is taken once daily in the morning with a meal. Shouldn't be taken within 4 hours of cholestyramine. Dosage forms are either in capsule, which can be swallowed, or capsules containing oral pellets, as you can see in the picture above, that are emptied into soft food, making it easy for little kids and puree-consuming infants to take. Maralixibat, which is trade name Liv Marley, and I'm using trade names only because I think some of us are familiar with the trade names. This is currently approved for use in the US for use in children with PFIC ages 5 years and older, as of actually last month, I believe. And previously it was approved for use in Alagille syndrome in 2021. This medication is taken twice daily for PFIC, although just once daily for Alagille. My understanding is that because it was shown that some children who didn't respond with once daily dosing did respond to twice daily dosing. And dosage form for maralixibat is either a capsule that can be swallowed or a liquid. So for both of these medications, they have a similar mechanism of action. They're similar in many ways. Neither of them are recommended for patients with severe or decompensated liver disease, kids probably who are listed for transplant with, say, ascites, variceal bleeding, or encephalopathy. I believe these medications were not tested in that patient population, and likewise, they're unlikely to have a significant benefit in any case, so they're not recommended. And likewise, they're not recommended for BSEP disease in patients who have severe ABCB11 mutations that are predicted to produce absent or non-functioning BSEP protein. And this subset of patients with BSEP were shown to not respond well and dropped out of trial. So it doesn't work in them. Most common side effects are GI-related: diarrhea, vomiting, abdominal pain. We see fat-soluble vitamin deficiencies. We see these in PFIC anyways, but they should be monitored. Likewise, some reports of blood and stool and bone fractures were reported in the Alagille trials. I think it's really hard to know if these were just due to the disease itself or related to the drug. But of course, we have to report all complications that develop during trials. Both drugs can result in elevated liver enzymes and/or bilirubin. This is more likely to occur the longer you've been using the medication. Usually it resolves spontaneously, but sometimes necessitates reducing the dose or stopping the medication entirely. And there has been frank drug-induced liver injury reported in, I guess, both maralixibat and odevixibat trials. So that's something to be mindful as well. So in the summary of what I was asked to talk about, there was a question of responders versus non-responders. So I'm addressing that by presenting some data from the Indigo trial of maralixibat in PFIC patients. And this trial was a study of 33 patients, 8 with FIC1 disease and 25 with BSEP disease. They were given maralixibat once daily for 72 weeks, and those who were still in study were watched for an additional up to 240 weeks, and non-responders were allowed to increase the dose at the beginning of that leg of the trial. In this trial, I'll point out there were some severe mutations, BSEP disease, and these patients did not respond. So this is, again, I'm trying to explain the responders versus non-responders. So they looked at a response by week 48, which was the first arm of the trial. And a response was defined by an ItchRO score. This is an instrument that assesses degree of itching. You wanted to see a reduction in the ItchRO score by at least 1 point. I can't remember if it's and or at least a 70% reduction in serum bile acid levels. And that 70% reduction was derived from the NAPID consortium data that showed that that degree of reduction in serum bile acid reflected a good response to a surgical biliary diversion. So that was, I believe, why the criteria were, these criteria were used to define responders. So in the responders, you can see there were 7 up here. 6 met the criteria for response at the end of the first leg in the trial, and 1 of them became a responder after increasing to twice daily dosing. And these patients had a profound and sustained serum bile acid and reduction and pruritus reduction. And none of these patients were listed for transplant within 4.5 years, which is pretty great. The non-responders, they did not meet these criteria. Notably, at baseline, they had worse labs than the responders did. They had worse liver labs, AST, ALT, bilirubin, and worse lipid panel indices. So it sounds like these patients were sicker at the outset of the study. So that's something to note. And again, as I mentioned before, all the participants that had severe or truncating ABC11 mutations were non-responders and quit the study. So then I just wanted to point out a few key points from the March PFIC trial that when it resulted, we've got Dr. Thompson over here who led that study, it led to the approval of maralixibat for PFIC in March. Yeah. And this was a study of a maralixibat BID dosing versus placebo for 6 months, and then an extension called March On. And these patients all had persistent moderate to severe pruritus and elevated serum bile acids. So you can see in this study, the reason I wanted to show a couple slides is just because this is not quite published yet, it's been accepted, but to point out that there was a all PFIC cohort that consisted of a subset of milder disease BSEP. That was 31 patients, and I think these patients had previously been shown to respond. So these were analyzed separately in addition to the whole cohort. And also there were participants that had FIC1 disease, MDR3 disease, TJP2 disease, and MYO5B disease. So this drug is approved for use in PFIC. It's not specific for any particular diagnosis of PFIC. And we'll see in the next slides that there was a response in all of them. So this is the primary endpoint of the study, was a response in the BSEP cohort. And you can see on the left here, here is the reduction in the itch row score, statistically significantly different in the maralixibat versus the placebo arm. And then over here, you can see the study week and the itch row scores over time. The placebo stayed pretty flat, whereas the maralixibat group decreased, up to about like 3 months in the study. They showed continued improvement, and it was sustained beyond that. And then here's the data for the FIC1, MDR3, TJP2, and MYO5B patients. They also responded. You could see the maralixibat reduction in itch row score on the left versus placebo here. And again, on the top, the placebo in the pink, and the maralixibat group on the bottom. So good response. So now I hope I'm not getting close to running out of time, talk a little bit about non-transplant surgery or biliary diversion for PFIC. So again, this is the same schematic that I showed earlier. This is a surgical procedure that results in kind of the same pathophysiology, the same physiology that you get with similar physiology that you get with the IBAT inhibitors. So what you're trying to do is to divert flow of bile acids away from the ileum here, where 95% of them are reabsorbed into the system. And you're trying to decrease flow of bile into the ileum so that the bile acids can't be reabsorbed. And there's kind of a twofold potential benefit of this type of surgery. Number one, you want to reduce itch. But number two, you could see a slowing of the disease process or an improvement, specifically of fibrosis. So okay, what are the possible complications? You need to be vigilant for development or worsening of fat-soluble vitamin deficiencies. You need to be cognizant that there still is an ongoing potential for periodic cholestasis disease flares. There is a possibility that liver disease will still progress and necessitate transplant, so you're performing 2 surgeries then, so that's something to keep in mind. And occasionally you can develop stoma or other surgical complications that necessitate a revision of the surgery. So who can benefit from these surgeries? FIC1 disease, this is the group that is most notoriously responsive to this surgery. Before transplant, you can use the surgery to treat pruritus, improve longevity of native liver. The thing about FIC1 disease is that response to surgery is difficult to predict. This is from the NAPID studies. Severity of gene mutation and serum bile acid level before surgery are not really predictive of your likelihood to respond. This surgery is also used after transplant in FIC1 deficiency. It can be used to ameliorate steatosis or fatty liver that can develop in the graft of FIC1 disease patients who have been transplanted. And as we heard a moment ago, it can also be used to treat bile acid diarrhea that occurs after transplant for FIC1 disease. In BSEP disease, these surgeries can also be very effective if you select your patients correctly. So again, treat pruritus, improve native liver survival. There is a much better response in those with mild ABCB11 mutations, with D482G and E297G being examples. Patients with truncating mutations that are predicted to have loss or non-function of protein are less likely to respond. But in those with mild mutations, the surgeries may extend transplant-free survival by up to 15 years, which is pretty amazing. Reduction of serum bile acid levels by 75% or to less than 102 micromoles per liter is associated with long-term native liver survival. and as I said, worse outcomes in those with more severe mutations. So there is actually somewhat of a predictive value in looking at the gene mutation in this disorder as opposed to FIC1 disease before performing these surgeries. So myo5B disease is also used in this disorder for isolated liver disease. So myo5B disease causes a cholestatic liver disease and or it could cause microvillus inclusion disease, which is a severe intestinal disease that can necessitate small bowel transplant. So in these kids, occasionally when they receive a bowel transplant, their new bowel, which is much more efficient at reabsorbing bile acids, following the small bowel transplant, they can actually have new onset or development of cholestatic liver disease. So biliary diversion surgery can be performed to treat this. And sometimes it's preemptively done during the small bowel transplant surgery. TJP2 and FXR disease, I'm not aware that there are any good data on response to biliary diversion surgeries in these patients, but overall they tend to be a little sicker, so they may not be ideal candidates in any case. MDR3 disease, it's not effective in affecting disease course in these patients, so we generally don't perform it for MDR3 disease. So procedure types. First, partial external biliary diversion. You can see here we're taking, we're resecting a portion of the small bowel and lifting it up, and we're attaching one end of it to the gallbladder so that bile can flow from the gallbladder through the little piece of small bowel and out through a stoma and into a bag. So we're basically draining part of the bile outside of the body. So pluses of this type of surgery are it's the most commonly performed procedure. Most centers have experience doing this procedure. It has a longer lasting benefit than ileal exclusion, which I'll discuss in a moment. Minuses are the stoma requires care, affects your quality of life, and there may be cosmetic concerns, particularly when kids get older and in their teens. Another minus is that if cirrhosis develops and is not recommended to do these procedures in kids with cirrhosis, varices can develop at the stoma site, pose a bleeding risk, can be very tricky to manage. So second one, partial internal biliary diversion. So rather than draining bile from the gallbladder to the outside of the body, you're diverting it by anastomosing it to the colon. So it will then be pooped out. So you're bypassing the ileum in that way. Pluses, there's no stoma, it's not visible externally, so it's very appealing in that way. Minuses are that emptying of the bile directly into the colon may cause diarrhea, but this can be managed with bile acid sequestrants. Another consideration is that you could develop chronic inflammation of the colon due to bile acid irritation. And the third one that I'll discuss is ileal exclusion. So basically what you're doing is you are you're transecting the small bowel and attaching it to the colon so that you are basically not using a part of the ileum. This is a part of the ileum that's not being used, and instead the small bowel contents here are going directly into the colon and being pooped out. So you are losing the absorptive capacity of that section of ileum there. So pluses to this procedure are you have no stoma, no biliary drainage bag, just like with the internal diversions. Yes, Emily. Okay, all right, I'm almost done. Because you're not using the gallbladder, you don't need to have an intact gallbladder. Minuses are that in this procedure you can develop severe malabsorption. It can affect nutrition. You can develop fat-soluble vitamin deficiencies. And another minus is that the intestine may adapt over time. So its absorptive capacity can increase and you can lose effectiveness over time. So in sum, this is my last slide, there are numerous medications available for the treatment of pruritus with different effectiveness and different side effect profiles. There is a potential to slow or reverse disease with ursodiol in BSEP or MDR3 disease. or with IBAT inhibitors. For BSEP disease, we know so far more data needed for other PFIC subtypes. The other medications we have are primarily aimed at symptom resolution. And biliary diversion surgery is also an effective option for medically refractory disease or pruritus in select cases, and or if you are interested in, reversing or slowing the progression of disease. So this is performed only in early stage disease, no cirrhosis. And good candidates are FIC1 disease, BSEP disease with mild mutations, or MYO5B disease. The type of surgery should be determined based on patient preference, experience of the surgeon, which varies by center, and careful consideration of possible complications. And I will wrap up.